Hi, I'm Dr. Kilpatrick. A low DXA score may look like osteoporosis. The DXA trap has led to misdiagnosed TIO and dangerous antiresorptive use.
Consider two postmenopausal patients. Both present with progressive bone pain, height loss, and multiple fragility fractures. Both undergo DEXA scans that reveal identical, critically low bone mineral density. Following standard clinical protocol, both are diagnosed with severe osteoporosis. Clinicians initiate standard antiresorptive therapy, typically bisphosphonates or denosumab, for both patients to address the low bone density. While patient A stabilizes, patient B experiences rapid skeletal failure. Her bones continue to fracture, eventually leading to severe mobility impairment and wheelchair transition. Patient B's decline results from a fundamental mismatch between the medication's mechanism and her actual underlying bone pathology. The driver of patient B's condition is a small, frequently overlooked phosphaturic mesenchymal tumor, or PMT. This tumor overproduces fibroblast growth factor 23, which forces the kidneys into persistent renal phosphate wasting. This leads to chronic hypophosphatemia. This is tumor-induced osteomalacia, or TIO. Because it manifests as defective bone mineralization and fragility fractures, it presents identically to osteoporosis on standard DXA imaging. This clinical overlap leads to an initial misdiagnosis rate exceeding 95%. On average, patients wait 3 to 7 years for a correct diagnosis. Prescribing antiresorptives based on DXA scores alone, without ruling out TIO, accelerates the destruction of the patient's skeleton. A retrospective analysis by Fang and colleagues examined 144 TIO cases to identify where the diagnostic process typically fails. This data visualization tracks 240 distinct instances of misdiagnosis among those patients. The largest volume of errors funnels directly into osteoporosis and intervertebral disc herniation. Clinical records show that 43% of these misdiagnosed patients had documented hypophosphatemia at the time of their incorrect diagnosis. Low bone mineral density on a DXA scan often creates a confirmation bias. Clinicians focus on the scan results and overlook abnormal serum phosphate levels already present in the laboratory reports. The failure to identify TIO is often a failure to account for routine laboratory data that contradicts the osteoporosis narrative. These diseases are pathologically distinct. On the left, osteoporosis involves excessive resorption of normally mineralized bone by overactive osteoclasts. On the right, TIO presents as a bone mineralization defect. Instead of resorption pits, soft, unmineralized osteoid matrix accumulates on the surface, compromising structural integrity. Bisphosphonates are designed to inhibit osteoclasts. In the osteoporotic bone on the left, they stop the resorption process and stabilize the existing mineralized structure. In the osteomalacic bone on the right, turnover is already deficient. Bisphosphonates enter and paralyze the remaining active remodeling units. By stopping remodeling, the drug prevents the body from replacing the defective, unmineralized matrix. This locks microdamage into the skeleton. Some first-generation bisphosphonates, like etridronate, can directly inhibit the mineralization process itself, inducing iatrogenic osteomalacia. This structural failure is evident in clinical data. 77% of patients with bisphosphonate-related osteonecrosis of the jaw show histomorphometric evidence of underlying osteomalacia. Administering bisphosphonates to a TIO patient creates a state of irreversible skeletal fragility. Denosumab, a RANKL inhibitor, carries unique risks in the context of TIO that go beyond the harms of bisphosphonates. This biopsy visualization shows the extent of remodeling suppression. In clinical trials, up to 38% of patients showed zero bone formation after 24 to 36 months of treatment, indicated here by the total loss of tetracycline labeling. In a TIO patient, this suppression of bone turnover freezes the mineralization defect in place, preventing any possibility of structural repair. Denosumab also exacerbates the underlying hypophosphatemia. By shutting down osteoclastic resorption, it eliminates compensatory skeletal phosphate. Serum phosphate levels decline further. Denosumab acts as a double threat. It structurally locks in the unmineralized matrix while biochemically depleting the patient's remaining phosphate reserves. TIO is surgically curable in over 90% of cases once the causative tumor is identified and resected. Following successful resection, the soft, unmineralized bone matrix rapidly calcifies and hardens. Serum phosphate levels typically normalize within days. This curative potential is lost during the years spent on an incorrect antiresorptive regimen. Prolonged disease and suppressed bone turnover lead to vertebral and skeletal deformities that may not reverse even after the tumor is removed. Delaying the correct diagnosis causes permanent damage to the patient's skeletal health. Current AACE and ACE guidelines list osteomalacia as a contraindication for denosumab, requiring clinicians to rule it out before treatment. A DXA scan showing low bone mineral density is no longer sufficient evidence to initiate antiresorptive therapy in isolation. A fasting serum phosphate panel must be a non-negotiable prerequisite for any patient with low bone mineral density before starting antiresorptive treatment. Closing this diagnostic gap prevents iatrogenic skeletal damage and ensures that patients with TIO receive the surgical intervention they require.